I couldn't really see any other way of really getting most of the topics covered and kind of keep this entertained other than keep moving. So please feel free to take breaks if you're tired and sleepy. I have the great pleasure of introducing two new speakers. Dr. Chandra is an electrophysiologist here in town. He does cardiology. He practices out of the eastern part of the city. A lot of people already know him. Dr. Vasovagal did his residence from Harvard Hospital, Washington, and his cardiology and EC fellowship from University of Oklahoma. And in fact, Dr. Jackson was his mentor. He's his mentor also. So he'll be joining us today to do a few cases, share his experience with some interesting cases. And then the second speaker of the day will be Dr. Mevan Vijayatunga. We already know him. He did his fellowship in cardiology as well as his fellowship from George Washington, and he currently practices in EP in St. Cloud, Minnesota. So he's also here to share a couple of interesting cases with us. So we'll try to do this a little bit quickly to kind of keep on track of time, and you can interject maybe at the end of the presentation. So we'll try to go one-on-one, and depending on the time permits, then we can do a second case. All right, thank you all.
Thank you, DJ, for inviting me for this symposium. We really had an excellent series of lectures this morning, and some heated debates, and I really enjoyed being here. I'm going to present one interesting case that I thought interesting for some of the seasoned electrophysiologists. It may be a routine case. I have no disclosures. This patient is a 61-year-old male. It was referred to me by a cardiologist for AF ablation. I mean, these days everything is AF ablation, It all depends on the AFs you can do, how fast you can do. But it's interesting, the symptoms were more like intermittent dizziness, lightheadedness, and it feels like he's going to pass out. And as he was admitted a couple of times. He underwent neurological workup. The CT was negative, and carried to doctor. Unusual workup echo. He's otherwise in a healthy state. He has no other comorbid conditions, and the usual workup was negative. So also physical exam, and as you can see, the Mumtag has become the most commonly used anti-arrhythmic medication in my practice. It doesn't really work well for atrial fibrillation. I don't know about you guys. But so he had an event monitor that showed some arrhythmia, and subsequently he was referred for ablation. This is his baseline EKG. Sorry, I couldn't bring a 12-lead EKG, but as you can see, it's a normal sinus rhythm. No pre-excitation. And this is the event monitor strip. It's always important to review the actual, for EP cardiologists. I think we need the strips and rhythms, and we need to review them. And unfortunately, sometimes we won't get them. But we're lucky in this case. We got this rhythm, a rhythm strip from the cardiac monitor, or cardiac event monitor. And it shows this runs of tachycardia. And it's kind of it's sinus rhythm, some couple of PFCs, again, that run. Kind of stops there, again, a regular narrow PRS tachycardia. And 200, 215 beats rather fast, and that probably making him light-headed and dizzy, very fast tachycardia. And we try to get as many clues from the rhythm strip. It looks like a short RP tachycardia. For those of you don't do EP on a regular basis, I mean, we try to characterize them into short RP and long RP tachycardia. So that is the information I got. I'm not convinced that he had atrial fibrillation from what I have seen so far. With that, I kind of talked to him, you're referred for AF ablation, but I don't think I certainly saw atrial fibrillation, but I tried to take you and see what we get in the lab, and depending on what we find, and we'll do the AP study, we'll try to ablate the relevant arrhythmia. So that's the kind of conversation I had with the patient. And here is, so this is the interesting part of what we do in EP is intracardiacs, and I try to orient you guys that don't necessarily spend a lot of time in the EP. The top to bottom, we have a surface leaves, and then followed by bicameral catheter. And then this is kind of a standard setup in Oklahoma. We kind of put a lot of catheters and try to get good intracardiac tracings. And believe me, they are a lot better in Oklahoma than I could do here. So put an octopolar piece catheter, and below that is a what we call a crystal catheter that has 20 poles from proximal to distal, and the right ventricular catheter is below. Then this slide shows you, I'm trying to pace the ventricle and see what kind of activation I have. I think the last, there's some ventricular block. And I want you to look at this tracing here. And it basically has a concentric retrograde VA activation. That's all you can tell from this slide, not a whole lot. Trying to see, is there an eccentric, when you have cases like this, you have an open mind and you don't know what the possibilities are. And all I can infer from this is there's a concentric retrograde activation. And this is parahisian pacing. And for those of you who don't know, this is one of the many things Dr. Jacqueline has taught, how to do this maneuver, and there are a lot of things were figured out in Oklahoma, and how to apply LPW, different kinds of AVNRTs. I can go on like this list. And parahisian maneuver is an interesting maneuver. It has, you put the catheter, ventricular catheter in next to the his catheter, and pace from there, and trying to see what is the retrograde activation, and we can literally spend an hour and trying to go through the details of the maneuver. But this is the complex. There is a Y here compared to, this is not the best example, but you can see when you do this, you have to see the activation is the same from this complex. This is his Purkinje RV capture, and this is more like RV capture. And from there, the interval is longer here compared to the one here. You can appreciate here more. And basically what it told me was there is no septal pathway. And from the original tracing I showed there is no free excitation, and there is no septal pathway. Here, the usual EP maneuvers, you try to pace the atrium and the detriment and see what kind of conduction you get. And basically, this tells you there is some evidence of slow pathway, and because this complex which is being paced is conducted to this ventricle, we go like that, and kind of following, and this gets blocked, this gets conducted again. So, conduction has evidence of slow pathway. Here, atrial extra stimuli. And it shows there is a what appears to me like this is the premature complex, stimuli we gave, conducted through the slow and up the fast, and that's all I can show from this. So as we move, we're into the procedure, we got tachycardia, which is, exciting. And as you can see, this has everything lined up, and there are two things, as soon as you have that, you say, oh, my day is going to be short, I'll be done soon, I can do 2 more consults with a device. That's the reality of private practice, how much more you can do in short period. Then, even though some of the alien artists are the most, toughest cases, if you ask Dr. Jackman, they can be the most difficult cases. We used to get a lot of referrals when I was there in Oklahoma for failed alien artists. So this is basically showing the atrium and ventricular, they're all lined up. It suggests to you as if this is alien artist, premature to say that. So at this point of time, what do you think is the diagnosis? I'm not asking you any of you. So we have these choices. Can be a AV nodal radiant tachycardia, AVRT, atrial tachycardia, which certainly we haven't seen any AV. I don't know if we can eliminate HE. It looks like AVRT, which again too premature. And the AVRT looks like little unlikely because we haven't seen ventricular excitation or any septal pathway based on the paratician. What should you do next? Should you ablate slow pathway or do pure ablation? I don't think anybody will do that. Need more information testing. I think that's probably what I hope you all agree. If you ablate and then decide it's too late, you need to know the diagnosis first before you ablate. And most of the time we spend in the lab, we want to know the correct diagnosis before we deal with the RF. Here, as we are working on and all of a sudden there is change in the atrial activation in the VA association was varying before they were all like this, and that tells me the rate of what we thought was a nodal dependent. Now there is some what we call wobble in the cycle end, and the VA interval has changed. And you spend more time, and I started seeing heavy block, as you can see, more A's than the B's. So it's just kind of, at this point of time, the diagnosis is clear because AVRT, you can't have AVRT with AV block, which is AV reciprocating tachycardia using pathway. AVNRT is also very unlikely. Most of the times you can have VA 2-to-1 relation than more, AV block. So I could start this tachycardia with, atrial premature complexes. I also use some isoproterenol in this case. With V pacing, we also are able to see this tachycardia, induce the tachycardia. So at this point of time, it looks like, from the same diagnosis we had, looks like atrial tachycardia. What we did was we used Weissen's-Webster's electroanatomical mapping using Cartlow. It was somewhat challenging because the patient goes into sinus and you have these few beats. You have to map them as they come in, and all of a sudden the tachycardia stops. So I started quickly map the right side of the atrium, also map for the, close to coronary sinus, which is a common area for some of the atrial tachycardias. Also mapped inside the coronary sinus. Nothing was really early. That's what we want to see, earliest activation. And this is a site which was, I had to do transeptum and get to the low septum from the left side, close to the coronary sinus. And I kind of tilted this map, which shows the lower, area, close to the septum. The location where we delivered the radio frequency patients and was able to terminate the tachycardia and statistically should the rhythm. We waited a long time, they couldn't induce any more tachycardia. This is not a great slide I want. I've tried to see some, show you what we call unipollars on the top, which were very early compared to the our reference up to 40 to 50 seconds early. So this was my final diagnosis, more like a left atrial tachycardia, low septal area. And I don't think I have a lot of time. In summary, septal atrial tachycardia should be kept in mind in the differential diagnosis of supraventricular tachycardia with concentric activation. Paralysis and maneuver is an important maneuver. And simply we saw a slow path, in slow path echoes doesn't mean it's just an ADMRT. And then people refer for AF can have other rhythms other than AF, what they were referred for. So, and it's also common and well known in EP world that some people have AFib and they're young and their actual rhythm is SVT. That degenerates into AFib, and common practice is to go out to the SVT and shoot them rather than do key regulation. I think that what was important in this case was careful history and planning in a way that I had an open mind and all the differentials in mind was I was able to help this patient. Thank you very much.
Availability of time, we probably do one to possible. First case, one person is a young man who was referred to me, actually a transfer from an outside hospital. He's a 22-year-old emergency medical technician, very active, physically healthy, and the gentleman was actually on duty one night for the ambulance. And he had a routine physical for his pilot exam. So the man was exercising, and he was doing some push-ups and sit-ups, and he was waiting for some emergency call. So he exercised, and then maybe he felt some irregularity of the heartbeat, and he continued to feel weak, lightheaded. So what the patient did was he walked to his truck, the ambulance, and hooked himself up to the EKG. And he felt, he had never had this before, and so his symptoms continued, and he saw some heart rhythm on the monitor, and it changed. Right. So, and then he woke up several seconds later, and he found, because when he fell, one of the EKG leads, EKG lead had fallen off. So, he didn't feel anything unusual because he was, very active guy. No symptoms. A little tired, a little sweaty, and what you expect after pain, and maybe a little tired. And so he went to bed and slept for a couple of hours, and then got a call to pick up a patient. So and he drove the patient to the ER, and he just told the ER, hey, I fainted, and showed that straight. And the ER said, saw this. So, and said, maybe you need to be in, connect, and then ultimately all calls were made and then transferred to patient. And then I see the man, and this is fiancé, I believe, and very healthy looking, and so I was even ashamed to see how physically active he was compared to myself. And then he asked these questions. the first thing comes to my mind, I'm cutting things short, young, healthy guy, and by the way, all the, investigations we had before, at the hospital, did an echo too, nothing was found, basic labs in the ER, echocardiogram. I mean, one thinks of exercise-related fainting, and obviously, if I didn't have that occasion, how often we have a patient comes with a straight failure and fainted. So, one need to consider exercise-related arrhythmias and hypertrophic cardiomyopathy, all that. But all the was excluded, and the questions posed at me was, it smelled like vasovagal, right, and gradually slowing down ready, and then have a long pause. So, and never had it before, and basically nothing in the history, nothing else, not even bradycardia for some non-vasovagal thing like even deep exposure that can have be having sort of. But the problem was he kept asking me whether he can pass his pilot's license. Of course, I don't issue them, but at least I had to make a commitment. And he is driving ambulance, so it's safe for him to bring a patient in, although he brought a patient to the ER right after his blackout. And of course, question, okay, so he asked, do I need a pacemaker and can I go back to get the license? So it put me into a spot where common sense said, well, that this man must have had a vasovagal event with predominantly cardio inhibitory type of response, or maybe a little vasodepressant cardio inhibitory, maybe a mixed response. And everything pointed towards that because you can feel the palpitations before passing out, and you get diaphoretic, which is a vagal response. And then fatigue has been described also as a vasodepressor phenomena. So I don't know what to write, but today I could have told him maybe go and see Dr. McElvey and have some yoga. But I didn't have that option. So, and I would be on the spot. So, just kept asking questions. Have you ever had any palpitations as a kid? Never. Have a passed out before? No. And then he kept pressing on me, okay, he needs clearance. So, okay, you can do tilt table. We all know about the specificity and density of tilt table, and I can say clinically, my degree of suspicion is pretty high. But except for this sort of palpitation, I said, well, you can have arrhythmias can lead to this kind of thing, but I don't know, if you want me to push, I can consider an EP study. Now, this is not the normal. I'm assuming how many patients with what we perceive as vasovagal symptoms, I guess only ultra fraction of them will take for EP study. Practically almost like a contraindication to do that. But this was a situation where I didn't have much to do, so I had to go for an EP study to exclude that ultra small possibility. So there are anything like, I thought of Sherlock Holmes who say, it seemed to be that after the examination of the room and the lawn might possibly reveal some traces of this mysterious individual. My Nicholas Watson, there was not one of them which I did not apply to inquiry. I don't say it, but Sherlock Holmes said. And so I had to discuss some traces, and but very different ones from those which I had anticipated. So I needed more information. I went to the previous medical history, no previous hospitalization, as I said, there was nothing there, except for that brief palpitation. I felt that I really got the word out of his mouth than, palpitations, and he said I had sustained palpitation. So, but then, dug into the history, we all know that, any type of arrhythmias can cause leading to syncope, but what I had was a progressive bradycardia and almost like vasovagal. But we also know that several arrhythmias can lead to vasovagal. I looked into literature, although we all know there's not much written, particularly about cardio response. In the 80s and 90s, there were reports on SVT associated autonomic reflexes. Once again, we are touching on the subject of Dr. McElvey, and autonomic reflexes associated with SVT. Now, we might think that just because you can have any type of arrhythmia, your ventricular filling time is low, your blood pressure drops, and it's a hemodynamic problem, so you pass out. But in this case, this was clearly with cardiomyopathy response. So I dug into the history, and of course there was a possibility with SVT one can have this problem. Now, so going into that, my diagnosis was either he had a vasovagal, which is primary, or maybe it is a secondary vasovagal due to an arrhythmia. And this was discussed earlier, so I don't want to get in there, but the simple explanation for vasovagal syncope, whether primary or secondary, is ultimately it slows down your heartbeat or the blood drops your blood pressure as a reflex mechanism. This was discussed earlier, so I don't want to spend time. And in a table, you see this, somebody can maintain the blood pressure and suddenly you drop the blood pressure or heartbeat. So, but in SVT and syncope, for example, this study, I believe, came from France. And had an incident of pre-syncope and syncope associated with SVT up to 18%. I don't know whether it reflects really what I see in clinical practice, but and the fact that one may have SVT in this patient cohort, a patient may have had palpitations for years, but it doesn't mean that each episode was associated with pre-syncope or syncope, and one may have stable symptoms for years, and then one time may have a symptom. And then on the other times, people might feel a little woozy and dizzy, and then the reaction somehow dissipates, or the body readjusts, so it could recalibrate. So these are too short to be noticed. And what are the mechanisms? Of course, a poor cardiac filling during rapid rates is a possibility, and also the vasovagal reaction at the onset or termination of tachycardia. Now that's interesting, because you may get palpitation and start feeling dizzy, and then you might get over, or the tachycardia suddenly terminate, and with the termination, then you get this sudden surge of the vasovagal response. And in elderly patients, particularly, if you have a sinus node dysfunction concurrently, and the tachycardia termination, of course, can lead to something like what we call a snurred lab, where the sinus node recovery time is prolonged, so that long pause can be a cause of syncope. And then, of course, other things like the conduction atrial fibrillation. If you have an accessory pathway that is capable of conducting rapidly, and when you have atrial fibrillation, and then subsequently can degenerate into ventricular tachycardia. See, this is an example, classical Holter. You have atrial fibrillation at the elderly, and the termination is associated with the sinus pause, and subsequently junctional escape, one mechanism. Another mechanism, which is termination of atrial flutter, again, because of sinus node dysfunction, there's a pause, and so on. Having said that, in the literature, I found it very difficult to find a tracing where SVT terminates into bradycardia, it's regular SVT, and this is from the article. And I would think that what I picked up in my patients was something related to the right side of this tracing. I never saw SVT. No, that was the assumption. And this is an example of another patient. I had this week atrial fibrillation conducted through an accessory pathway, and you can see the presence of pre-excitation, particularly when the atrial fibrillation terminates. So that's another mechanism for syncope in these patients. And to cut things short, our patient had an EP study. Indeed, I found a lateral accessory pathway in the patient, and the patient went well. Now the question was, is that the main culprit? And only the time could say. And now, about a year later, I saw him follow up in 6 months, and told him the contract is necessary, and he had not done so. So again, going back, how do you separate the primary vasovagal from secondary? Again, the classical symptoms of vasovagal, the patient presents with almost always we believe that we don't need any more testing, but primary arrhythmia may be a possibility if the patient gives you idea like it's a sudden onset vasovagal symptoms or sudden offset and associated palpitations. The presence of structural heart disease may imply there may be some other than SVT kind of mechanism or underground EKG. And again, So who I have conclusive diagnosis, so I turn back to the Sherlock Holmes who say, when you have eliminated the impossible, whatever remains, however improbable, must be the truth. So that's my first thing. Any questions? Is that good time? Well, shall I switch on to the second piece quickly? I don't know, let's just go on here. Another young lady who was again referred to me, a 49-year-old lady, the previous history of, actually ongoing history of rheumatoid arthritis. Might have a replacement and an ICD at another institution some time ago. And I was consulted at an outreach clinic, but this lady had so-called paroxysmal atrial fibrillation and had an atrial leak. They were trying to readjust, never got good sensing in that atrial leak. And also said he had some non-sustained VT and amiodarone for 6 years, so in a 49-year-old lady. So I was getting quite nervous, and I wasn't really, I got the idea of where and how she does ICD and what for. And the ECG at that time was atrial based, but the ventricle is conducted and an incomplete right muscle. And 9 months ago, I had an EKG report saying ejection fraction is 50%, but end-diastolic dilation a little bit the larger side. What happened was I said, let me gather some information on you. I need more information to move on. I'm concerned about your amiodarone 6 years, and you're still young, and the issues are not really mind-breaking right now. Let's get the information. But my next clinic visit was a month later at the same location, but in between, they called me and said she presented with VT and shock. So one of my nurses was diligent in getting records, and it said she had an EP study done in 2006 at another institution because she was referred for some PVCs and some palpitations, so it was still not very clear what kind of PVCs. And they induced a tachycardia with the left bundle and inferior axis, and the transition between V4 and V5. May not be very typical for RVOT because the transition is a little delayed, but the anti-tachycardia pacing could stop it. So she ended up in a defibrillator and then put on amiodarone. And this was the EKG when she presented with shock, as it's the atrial pace and the ventricular sense, occasional PVC, and this is all it had, positive in 2, but negative in AVF. So it may not be like a typical RVOT type. So I know this was in my mind that, normal looking LV, well-V, but VT, and which we can see the VT picked up on the telemetry in the emergency. So, and she was an amiodarone, and the options, so what is this VT, why? And by the way, she was still having normal coronaries, so it's non-ischemic something going on with this lady. And then again, I was nervous. For God knows amiodarone, but how long? And the patient felt very incomplete. So we decided to, this is the information, so I decided to go for an EP study. Why? At least to know what's going on. And then, at that time, I got an echo. It said ejection fraction 45%. So, and I had no VT to rely on a 12 EKG at that time. And then with an EP study, she had some inpatient delay. But again, monomorphic VT could be induced, independent of varying morphology with the conduction delay pattern and left funnel. But luckily LV and LVOT couldn't get anything. So, it was also a little bit of a paradigm shift there. Now I'm, okay, so shall I go to the right side? And this was the VT I used. So, it's, lead 1 is positive, and it's a left funnel, so I was thinking more on the sector side of LV, but, then I switched to the right side, and here I found it there. This is an ESI map. At the top, right, almost like an infundable area of the right ventricular, right ventricle. So, and then upgraded it, used isotope vertical, and it went away, at least for the time. And then I was sitting back, I have a lady with recurrent VT with a left bundle morphology coming from the right side. And I found a large area of fractionated electroplans in that area. And she had EKG changes, maybe like showing some incomplete right bundle, T-wave inversions, lead V1 from T, and with that, of course, now the story is revealing, and signal average EKG showed unique potential. So what do you think? Yeah, that smells more like that, right? Yeah, exactly. And so for me, I'm telling the story, it was a moving target. It was not so clear at the beginning. And I had to keep changing the game plan all the time. And of course, we're having a non-MRI compatible device. So I had to go for a CT, and a CT showed hypokinesis of the RV, enlargement of RV, and scalloping of that area. So the pictures were consistent with the electrograms. And this is the one can appreciate we try to find so to be fair, I now switch to this screen because everybody was fighting it. So this is the RV which is enlarged, even I believe, and electrophysiologists can appreciate that. And here one can appreciate that this segment is moving against, so it's basically not hypokinetic, it's distant. It's not going in with systole. And of course, with LV, it's also globally down. And so this is what the scalloping they call in the infundibulum, and then once you get that defibrillator. So everything smells towards the ARVD in this area. The differential diagnosis could this be some global cardiomyopathy or sarcoid, and that remains. So that, of course, the ARVD, the right ventricular dysplasia or cardiomyopathy, is predominantly right ventricle, but can spread to the left ventricle, as you know now. So, and again, here, this is not this patient, but to the left is the MRI, which shows the usual fibropathy replacement of the muscle. But this is that mitration, and one can really appreciate this infant right below the the pulmonic artery. This is that enlarged area that right the VT came from. And from inside, there will be traveculations inside too. And what I did was here, over the years, I went in doubt. Of course, this is getting quite clear cut, but not every patient comes like this. But I do a right ventriculogram, and I follow the protocol by Dr. Frank Marcus in Arizona, and I don't know how to read it, so I'll send it to you. So, and this is, and he has a standard protocol, and he has been immensely helpful. And I'm not advertising for him. I haven't spoken to him in person other than emailing, but I have to tell you, personal experience, he would be happy to help you out if you need it. He's quite passionate. It's free of charge. I believe no liability. So, and again, once again, Dr. Marcus reconfirmed it, but this is a very clear-cut case, not much doubt, but one could see that top part of the RV with infundibular, and then also trabeculation. So, my time is getting over, so again, the brief background on the RVD, one can see the fibropathy infiltrate of the RV, or in this case, biventricular. And I'm trying to say this lady, I don't do that. So when trying to say this lady had the genetic screening because of the kids that had a desmoplakin abnormality, I went on to do a biopsy, which was analyzed at the Mayo Clinic and came out to be ARVD. And so she's now having recurrent VT. And I tried another ablation. She was screened for another 6 months. Now she's on dual antiarrhythmics. I'm using sotalol and Exility and quiet, but she's now being evaluated for transplant at Mayo Clinic for the time because this is a progressive disease. Thanks for your attention. If you have any questions, I quickly take.